Hello guys. So in this video, we are going to discuss about the diagnostics and the clinical examination in orthodontics. Specifically, we are going to talk about the various diagnostic aids and extraoral examination. We have made another video for intraoral as well as functional examination so that you guys have a clear understanding about each aspect of the diagnosis and clinical examination. So going into the orthodontic diagnostic aids. Orthodontic diagnostic aids can basically be divided into two types. The first is the essential diagnostic aids and the next are the supplemental diagnostic aids. So essential diagnostic aids means before starting any orthodontic treatment, all these are essential. You do not start the treatment without these diagnostic aids. However, case by case basis, if any special diagnostic aids or these supplemental diagnostic aids are required, you can advise for it. What are the essential diagnostic aids? The essential and the supplemental diagnostic aids are an important MCQ question. So, what are the essential diagnostic aids? First is your case history and clinical examination. You need to have the patient's case history. You need to examine the patient clinically and have the details with you. Second is the study models. Third is certain radiographs like IOPA, OPG, and your bite wing. Cephalogram, lateral cephalogram is not an essential diagnostic aid, it is a supplemental diagnostic aid. Your bite wing, your IOPA, and your OPG are essential diagnostic aids. Next is both extraoral and intraoral photographs. Coming to the supplemental diagnostic aids, specialized radiographs include your lateral cephalogram. If there is any impacted tooth, you can take different occlusal views of X-rays or CBCT. These are specialized radiograph. Skeletal maturity assessment. If the patient has any skeletal malocclusion, you need to assess the growth of the skeletal growth of the patient. You can advise either hand wrist radiograph or an MP3 radiograph or a CVMI stage assessment using the lateral cephalogram, using the supplemental diagnostic aids. Any growth hormone deficiencies or hormonal issues, you can advise a hormonal test. In patients who have severe crowding, you are not aware of how you are going to do the extraction or how you are going to create a space, you do something called as a diagnostic setup. You take the impression of the patient, you section the tooth, you simulate the treatment on the cast and see how the occlusion, how the overjet, overbite, and the alignment is going to be when a specific tooth is extracted, and you plan your treatment accordingly. Next, occlusograms if required, electromyography if there are any muscle related issue. So there are two different diagnostic aids, essential and supplementary. Your lateral cephalogram, I repeat again, is not an essential diagnostic aid. So coming to your case history, this is quite straightforward. You have been doing this in your from your third year. So chief complaint is basically what the patient wants from their own words. So what do they want to correct? Do they want to correct? Generally, orthodontic chief complaint will be not a tooth that is not aligned or irregularly placed tooth or forwardly placed tooth or gaps between the tooth. These are very common complaints. Very rarely patients say that my jaw is very big, my face is a little crooked. In very rare cases where there is a skeletal malocclusion associated, you will see such chief complaints also. So addressing the chief complaint is very, very important when you are incorporating your treatment plan. Next is the age. Age is a very, very important criteria because orthodontic certain treatments depend on the age, especially when you're treating a skeletal malocclusion. If the patient is very young, you cannot directly go for advice orthognathic surgery. You have to try some amount of growth modulation, or if you're doing a camouflage. So age is a very important criteria when you're deciding treatment plan. So assessment of age, also the skeletal age in certain situations is very important when you take the case history. Next, regarding the sex or the gender, generally females mature faster. So treatment of skeletal malocclusion of females must be done earlier compared to the males. Medical history, you need to know what are all the diseases the patient has, any that could affect the orthodontic treatment, or the patient has any allergy to any material, commonly nickel allergy, you need to document. Or if the patient is under any drugs, the drugs that can slow down the orthodontic tooth movement, all those things you need to record. Next, dental history, their caries history, their periodontal health, their any extraction history, all those you need to take a note of. Postnatal and prenatal history. Why is this important? Is certain skeletal malocclusion develop because of some prenatal or postnatal factors. Prenatal factors will be there is something called as uterine molding. The child, when it is inside the uterus, will have a molding from the chin like this. So those patients are tend to develop mandibular retrognathism. Also, forceps deliveries are known to cause TMJ disorders and cause TMJ ankylosis, and can develop some sort of open bite or a retrognathic mandible. So these in histories, if they are there collected from the patient, it is easier for us to diagnose, to arrive at a proper etiology. Next, family history. Sorry. Certain malocclusions are familial. The parents will have a similar face structure and a dental form. The child will also have a similar one. Most common familial malocclusion is class 2, division 2 malocclusions. They have a very common familial tendency. Next, deep bites, bimaxillary protrusion, and crowding. These are very common familial malocclusions. The parents or the siblings, if they have previously had any sort of treatment to any of these issues, you can know that this patient will also have a similar issue in the future. So general examination is basically your height, weight examination, their mental development. You should also assess their psychological status, their willingness to undertake treatment, their motivation for treatment. If it is generally, there are two types of patient: intrinsically motivated patient and extrinsically motivated patients. Intrinsically motivated patients is that they want to get treated, so they are very cooperative during the treatment. Extrinsically motivated patients are children who are forced by their parents to undergo treatment. So these children will generally not cooperate, they will not maintain oral hygiene. So you need to understand their motivation even before starting the treatment, so you can be little more careful when you're dealing with such patients. This the extra general examination involves the examination of the build. This classification was given by Sheldon. Sheldon's classification of the build, based on how the patient is built, he has classified into 3 types: the ectomorph, endomorph, and mesomorph. Why is this important? Why do we need to know how the patient is built? Is because the same way they are there in their body, it is going to reflect in their face. It is going to reflect in their arches. So treatment planning will start from examining their body. For example, ectomorph are generally tall and thin. They have a long face, so they will have tendency to anterior open bite more. They will have a high arched palate, high arched and a narrow palate. So treatment planning for such patients will be different than an endomorph. Endomorph are slightly shorter and wider kind of body type. They will have a more horizontal growth pattern, tendency for a deep bite, wider arches, so they will have a lot of space. So these are endomorph. Mesomorphs are average patients. They will have average build, and their face also will reflect the same. So Sheldon gave this classification. It's an important 1-mark question: ectomorphs, endomorphs, and mesomorphs. Coming to extraoral classification, starts with your head. So the first is your cephalic index. The cephalic index was given by Martin and Saller. The body build classification was given by Sheldon, and the cephalic index was given by Martin Saller. Just like I said, based on the width of the skull, we classify the skull into, by dividing the width of the skull, maximum width as you can see here, divided by the skull length. So when you divide these two values, you get a percentage. Based on this percentage, you classify it as dolichocephalic, mesocephalic, and brachycephalic. Dolichocephalic corresponds to ectomorphs. The skull is long and it's not that wide. Mesocephalic is average. It corresponds to mesomorphs. Mesomorphic body type, as we saw before. Brachycephalic is more wider and less smaller in the length of the skull, and it corresponds to endomorph. So the body type, the skull type, and next is the facial index, everything is going to be very similar. So if it is less than 75% is the dolichocephalic, 75 to 80% is mesocephalic, greater than 80% is brachycephalic. Next, we are seeing the facial index. Facial index was also given by Martin Saller. Both cephalic index and facial index were given by Martin Saller. This, how do you classify, is the facial height by bizygomatic width. Facial height you classify from nasion to nasion bizygomatic width. Nasion to nasion divided by the bizygomatic width. If you measure, you will get certain values. Based on that, you classify it as euryprosopic, mesoprosopic, and leptoprosopic. Leptoprosopic corresponds to an ectomorph and dolichocephalic. Mesoprosopic corresponds to mesomorph and mesocephalic patients. Euryprosopic corresponds to endomorph and brachycephalic patients. Right. So this is the facial index. This you need to measure, and this is basically 1 mark related. They will ask you the landmarks based on the values. They'll ask you to classify. So all these you need to remember. So this is a description. This you can see euryprosopic. This is the mesoprosopic average face. This is more a wider face than a longer face. This is balanced, and this is a very long face. So long faces are leptoprosopic. Round faces, which are more wider, euryprosopic, and balanced face is a mesoprosopic. So coming to frontal examination, the first thing you need to look at a patient is the symmetry. So it is to be known that not all patients have exact symmetrical face. You can see in this image, this is the normal photo of this patient. So what they have done is something called as a composite photograph, composite image or a photograph. So what they do is they split the image into half, and they just replicate the mirror image of this side here, and this is the mirror image of this side. As you can see, this face and this face are different. So one half of the face is slightly asymmetric compared to the other half. So all patients are completely symmetrical, but any gross facial asymmetry, if it exists in patient, especially the chin or in terms of the nose, you need to know it. So important 1 mark question is, what is used in identification of facial asymmetry? Composite photographs. There is also a view called bird eye view photograph, in which you make the patient lie backwards. You take a picture from the behind just with the chin. For chin asymmetry assessment, that type of photographs is taken. So overall complete comprehensive examination of your asymmetry, you take a frontal anteroposterior cephalogram or an AP cephalogram or a CBCT to confirm the asymmetry, and the cause for the asymmetry can be assessed using an anteroposterior cephalogram and a CBCT. Coming to the facial profile, very common. You make this patient the sit, and you see what is the profile of the patient. So what are the landmarks involved in profile assessment? There are 3 landmarks. So basically your glabella, subnasal, and your pogonion. So glabella is a soft tissue forehead. Subnasal is the most deepest point on the soft tissue contour of your upper lip. Pogonion is the most prominent point in your chin. So when you connect these 3 points, what is the shape you get? And that is your profile. This is also called as poor man's cephalometric analysis. It's an important 1 mark question. So is it convex? Is it straight or concave? Convex profile is commonly seen in class 2 patients. Straight profile is seen in class 1 patients. And concave is seen in class 3 patients. It is commonly seen, but doesn't mean that a class 3 patient cannot have a straight profile. But generally, if the patient has a convex profile, the patient will move towards a class 2 side. Straight profile class 1, concave profile class 3. It is called as a poor man's cephalometric analysis because just by looking at the patient's profile, you can tell if the patient is having a class 1 malocclusion, class 2 malocclusion, or a class 3 malocclusion. Because only when you take a lateral cephalogram, you can do cephalometric analysis and tell what is the skeletal relationship of the patient. But just by looking at the profile, you can have a very vague idea in skeletal patients about where the malocclusion is going to lie. So this is regarding the facial profile. Facial profile, 3 points are there: glabella, subnasal, and pogonion. When you connect it, there are 3 facial profile: the convex, straight, and concave profile. There is another aspect to this called as facial divergence. This was described by Hellman. So, in facial profile, there were 3 points, but in facial divergence, there are 2 points. From the forehead, you drop a line to the chin, like this. Drop a line to the chin. So you can see this line is going more from the forehead. It is going back. So this is called as posterior divergence. From the forehead, it is falling straight down. This is called as straight divergence. In this patient, from the forehead, it is going forward. So this is called as anterior divergence. So the projection of the chin in relation to the forehead can be assessed using a facial divergence. So posterior divergence, as you all know, commonly seen in class 2 patients. Straight divergence is seen in class 1 patients, and anterior divergence is seen in class 3 patients. So the next aspect of the extraoral examination is something called as the facial fifths. So you divide the face into 5 different segments and look for symmetry. So if all these regions are proportional or not. So the separation of the eyes, you can see the separation between the inner and the inner canthus, between the outer canthus and the face that is visible. So draw 5 lines, and you have to see that if all these 5 segments, facial fifths like they say, are proportional. So the width of the nose should be the same or slightly wider than the center fifth. The interpupillary distance should be equal to the width of the mouth. So if it is not the same, there is some issue with the proportions of the face, and that could cause some aesthetic problems. Next, coming to facial thirds. This is in the anteroposterior region. In the vertical pattern, there is something called as facial thirds. You divide the face into 3 halves and see if all the 3 halves are proportional. So all the 3 should be the same to have a mesoprosophic face, but you cannot expect that from a uriprosophic patient or a leptoprosophic patient. So lower third, the distance from the hairline to the base of the nose, distance from the hairline, you can see here, to the base of the nose to the bottom of the nose to the chin. So this is the first, second, and third halves. Right. Lower third is the lower third can be divided into 2 halves, upper 1/3 and lower 2/3. So we can know what is the reason. Suppose the patient has a very long face. Which aspect is contributing to the long face? We'll be able to tell when we do this facial thirds examination. Next is the examination of the mandibular facial plane angle. So in the video where we have described about growth, we talked about something called as growth rotation. So the jaw does not grow linearly, it also rotates. So what happens when the jaw rotates forwards or backwards is that your face length is determined on that. Deep bite or anterior open bite is determined on that. For example, the mandible is growing in a clockwise direction or forwards and upwards. There is going to be a tendency for more deep bite. If the jaw is growing backwards, the face is going to become long and there is a tendency for open bite. So clinically, what is the growth rotation or the growth angle of the patient? We'll be able to determine using cephalograms definitely, but clinically you can assess by the method of assessing the clinical mandibular plane angle. So you take any instrument, the back of your mouth mirror, keep it along the lower border of your mandible like this. And another instrument you can take and you can keep it like this. So you can see that both the lines are going to meet just behind the occiput here. So when it meets behind the occiput, it means that the patient has a normal vertical growth pattern. For example, if the patient has a severe deep bite, the mandibular plane is like this, and they are both these lines are parallel with each other. As you can see, it will definitely meet way behind the occiput here. So that means the patient has a horizontal growth pattern. However, when the patient has a severe vertical growth pattern, it is going to meet in front of the occiput. In front of the occiput. So the patient will have a vertical growth pattern. So clinically, you can assess this even without a cephalogram. So this examination you will be doing, this is very, very important when you are giving your practical exams during your final year ortho examination, and also to an extent 1 mark questions can come from these topics. Next is the examination of lips. So how are the lips related? The first one, there are 3 types of lip classification. First is competent. This is potentially competent. The third one is incompetent. So competent, as you know, at rest, the lips will be contacting each other without much perioral strain. You can see the perioral muscles are relaxed. The lips are able to contact. There is no gap between the lips. But in the second picture, you can see the patient is not able to close her lips. There is this tooth that is coming and interfering. But when you push the tooth back, the lips have good musculature. It will be able to close. So potentially competent patients, the incompetency of the lips is due to any sort of dental malocclusion or dental proclination. The patient can achieve lip competence once we correct the malocclusion. However, you see a third category here. The patient's tooth is not proclined. However, the lips are short. You can see like this. The philtral height, the distance between the base of the nose and the philtrum to the base of the nose and the lip commissure, there is a drastic difference. You can see in this picture, the first image where the patient has a competent lips, the philtral height and the commissural height are almost the same. This is the philtral height. This is the philtral height and this is the commissural height. But for this patient, the philtral height is very small because the patient has a anatomically short lips. So when the lips are short and your jaw is normal, your lips has to be strained to close your lips. Normally, when the muscles are relaxed, as you can see in this patient, you will not be able to close your lips. So even when the malocclusion is corrected, for such patients, the patients will still have difficulty in closing their mouth. This is called as incompetent lips. I'll show you an image. Yes. So this patient has an incompetent lip. In the means of closing the lips together to achieve a lip seal, there is a hyperactivity of this mentalis muscle. You can see here, there is a tension here like dot dot on the chin. This is called as hyperactivity of mentalis. So when you're examining patients with lip incompetence, you need to note if the patient has a hyperactivity of mentalis. This is also called as golf ball appearance. You would have all seen golf ball, right? It's a small white ball with small dots. It is very similar to that. It's like a round thing with small dots due to the contraction of the mentalis. So this is called as golf ball appearance, commonly seen in patients with hyperactivity of mentalis, commonly in patients who have incompetent lips. The next comes lip step. Lip step has been described by Korkus as anterior lip step, normal lip step and posterior lip step. So from the upper lip, when you see the lower lip is slightly forward. It is called as anterior lip step. Generally, the lower lip step, the normal lip step will be slightly posterior. The upper lip will be in the front, the lower lip will be slightly in the back. So this is the normal lip step. However, in posterior lip step, you can see there is a severe posterior step. This is called as posterior lip step. So lip steps classification was given by Corcus. This anterior lip step is commonly seen in class 3 malocclusions, normal lip step seen in class 1 malocclusions, and posterior lip step in severe class 2 malocclusions. So this you need to identify. Next, coming to, we have looked into the lips, overall face, the symmetry. We saw about the lips, the competence, the lip steps. Now we are going to see the nose. So normal horizontal vertical length and horizontal ratio is 2:1. 2:1 is the normal ratio. The length will be 2 and the depth of the nose will be 1. In certain patients, they will have a microrhinic nose. They will have a short nasal rib, upturned nose. This is called as an upturned nose. Generally, the nasal bridge will be down. In some patients, the nasal bridge will be upturned. You can see the nares from outside. So, the upturned nose, short nasal bridge is what is. This is called as a microrhinic nose. In this, the patient has a very large nasal bridge and a very protruding tip. So this is also abnormal. This is the normal. 2:1 ratio is considered to be normal. This looks like 2:2. However, this looks very short. So this is the normal ratio. Next is the nasal contour. Nasal contour slightly has a convex outline. However, in some patients, they will have a very straight outline. In some patients, they will have a convex outline, like a hump nose. This is an abnormality of the nose which might require some correction. And also in some patients, the patient will have a deviated nasal septum. In the front, you can see it like a crooked nose. So straight nose, convex nasal bridge and hooked nose are abnormalities in nasal contour. Next is the nasolabial angle. So this is the angle made by the naso means nose, labial means lips, angle made by the nose contour and the lip contour. So the normal nasolabial angle is 90 to 110 degrees. So this is the normal nasolabial angle. It can be either increased or decreased. If it is increased, like it is more than 110 degrees, it is an obtuse nasolabial angle. If it is decreased, it is an acute nasolabial angle. So what are the factors that can affect the nasolabial angle? So there are two components, right? Nose and your lips. So the position of the nose and the position of the lips is going to affect the nasolabial angle. Like I said before, if the nose is upturned, if the nose is not straight like this, it is going up, the nasolabial angle is also going to be increased, even when the lip part is proclined. The lip commonly in patients who have a small nasolabial angle will be due to the lips because of the dentition. Patients who have proclined upper incisors, the lips also will be forward. So when the lips are forward, the nasolabial angle is going to reduce. When the lips become more and more forward, come forward, the nasolabial angle is going to reduce. So you can see in this patient, this is a normal nasolabial angle. It is close to 90 degrees. But in this, the patient has a severe obtuse nasolabial angle. The nose is normal. However, the incisors are severely retroclined. So the lips are farther back than what it should be. However, in this patient, you can see the nose is also upturned. The lips are also, you can see a severe proclination of the upper lips. This is a very acute nasolabial angle. It is less than 90 degrees. This is more than 110 degrees. So acute nasolabial angle has treatment implications. You have to bring the nasolabial angle to 90 to 110 degrees. So you cannot change the nose. So all an orthodontist can do is change the position of the lip. So when the patient has acute nasolabial angle, we can do pull the incisors backwards so that the lips also move backwards and the nasolabial angle improves. Or in patients like this with severe obtuse nasolabial angle, if the incisors are severely retroclined without any lip having no support, or the patient is having severe maxillary retrognathism, we can bring the incisors and the maxillary dentition forward so that the lip gets adequate support and the nasolabial angles reduces. So like I said before, This is a golf ball appearance. And patients who have a very short upper lip have a appearance of something called as a gull wing appearance. The lips will have a gull wing appearance. You would have all in your childhood have drawn birds like this, right? Like this. So very since the lip has to be straight, in this patient the lips will be like this because the philtral height will be short, the commissural height will be large. So this is a shape of a gull wing, wings of a seagull. So gull wing appearance like this you draw, right? When we are drawing when we were very small to draw birds. So this is called as a gull wing appearance. It is an important 1-mark question. So going to the amount of incisor and gingival display for ideal smile, 100% incisor display with minimal gingival display is what is expected. Up to 4 mm of display of gingiva in addition to the crown of the tooth, or up to 4 mm lip coverage of the incisor crown is considered acceptable. Generally in females, 2 to 3 mm of gingival show is considered aesthetic. However, in males, gingival show is not considered very aesthetic. So up to 2 to 3 mm of gum exposure during smile is considered aesthetic. Next, going on to buccal corridor space. Buccal corridor space is basically your space you can see in this image. The black space, posterior, that lies from the premolar region to the corners of the lips. You can see this is the buccal corridor space. Generally, very wide buccal corridor space indicates the maxillary arch is slightly narrow. So a wide buccal corridor space is not considered attractive for a smile. You can see in this patient has a very wide buccal corridor space because of the narrow maxillary arch. The patient has been treated now and has a wide smile. The buccal corridor space is very narrow. So a very narrow buccal corridor space is considered to be aesthetic. You can compare the images. So the buccal corridor space is very wide in this patient compared to the buccal corridor space in the case which has the maxillary expansion has been done to relieve the narrow arch. Then smile arc. Smile arc can be classified into 2 types: consonant, non-consonant, and reverse smile arc. So consonant, basically a smile arc, you can see in this image B. The incisal edges have to follow the contour of the lower lip. When this happens, it means the smile is consonant. If the incisal edges do not follow the contour of the lower lip, then the smile is called as non-consonant. However, when the incisal edges curve away from the lower lip contour, it is called as reverse smile arc. It is seen, the reverse smile arc is commonly seen in patients with anterior open bite. So this is regarding the smile arc. So that's all regarding extraoral examination. I hope I have covered whatever I could. If you guys have any doubt, feel free to comment in our Telegram group or through our Instagram page. Thank you.